butterfly lesions. Let's think a little bit more about deep white matter and periventricular lesions. Gliomas, astrocytoma and oligoastrocytoma, and lymphoma, usually primary lymphoma in the central nervous system, are the classic lesions that expand by infiltrating the corpus callosum. Toxoplasmosis in CMV may involve the ependymal lining of the ventricle and the periventricular area, and various types of white matter disease or leukoencephalopathy, small vessel disease or arteriolar sclerosis, and infarcts that may be the result of hypertensive vascular disease may also involve the periventricular region and the corpus callosum. However, these lesions classically are associated with volume loss. Of course, these small vessels affected by hypertension may produce hemorrhage in a similar location. The classic butterfly lesions include the necrotic ring-enhancing lesion of a glioblastoma multiforme, the highest grade of diffuse astrocytoma, as well as the fluffy hyperattenuating lesion relatively homogeneous for primary CNS lymphoma. Both of these lesions are microscopically infiltrate and follow along the white matter tracts as they pass from side to side through the corpus callosum. Let's talk a little bit more about CNS lymphoma. CNS lymphoma represents 2 to 3% of all primary brain tumors. It is usually a non-Hodgkin's B-cell lymphoma. It is usually primary within the central nervous system without any extra CNS locations. It's usually within the brain parenchyma in a pericentral deep location involving both the gray matter and the white matter, and it may spread around the ventricles. In contrast, secondary CNS lymphoma is usually extraaxial, involving the dura and or the leptomeninges. So primary brain lymphoma typically is this hyper-attenuating lesion on the non-contrast CT scan because this is a classic small, round blue cell tumor. Because the cells have a lot of DNA and they're very closely packed, they can attenuate the X-ray beam. Because they have decreased water, they may be dark on the T2-weighted MR. They can have restricted diffusion and be bright on DWI and dark on the apparent diffusion coefficient or ADC map images. The lesions lack a blood-brain barrier, so they always show abnormal enhancement in the corpus callosum. And again, the classic localization is in the periventricular area, and lymphoma is usually primary within the central nervous system. It's almost always a B-cell lymphoma. In fact, solid non-hematopoietic lymphomas are almost always B-cell lymphomas, and circulating or hematopoietic lymphomas are usually T-cell lymphomas. Here is a classic example of a primary CNS lymphoma on MR scanning. We have FLAIR T2 and a T1 weighted image with gadolinium. The lesion is dark on the FLAIR image. It shows contrast enhancement after gadolinium is given, and the lesion is also remarkably hypointense on the T2 weighted image. And again, this appearance of low signal is due to the cellular packing and the high nuclear to cytoplasmic ratio of each one of the cells in this small round blue cell tumor. Here's another example of primary CNS lymphoma in an immunocompetent patient. We can see that the lesion on the T2 weighted image is remarkably darker than CSF in the ventricles and darker than the perilesional vasogenic edema. We can also see that the same areas show contrast enhancement once gadolinium is given on the T2 weighted images. So this was an immunocompetent patient who has solid enhancing lesions of primary CNS lymphoma. In contrast to primary CNS lymphoma, which usually has a very homogeneous pattern, when we have primary CNS lymphoma in an immunosuppressed patient, we may have ring-enhancing lesions, which may be difficult to distinguish from toxoplasmosis, which also occurs in immune-suppressed patients. This particular patient was HIV positive and went on to have full-blown AIDS. Primary CNS lymphoma tends to involve the periventricular area. In this example, we can see abnormal hyperattenuation surrounding the right lateral ventricle and corresponding abnormal periventricular enhancement after iodinated contrast material is given. And so we want to remember this appearance of a lesion that is hugging or surrounding the ventricle. One of my colleagues calls this rymphoma because it forms a rim around the ventricular system. So CNS lymphoma is usually parenchymal, paracentral, hugging the ventricles. It's a small round blue cell tumor. It can be multifocal, and when it creates a ring-enhancing lesion, the rings may be irregular and have a wavy or undulating margin. We can also do special metabolic studies, including SPECT, thallium, and FDG studies, in order to be able to demonstrate the increased metabolism of this neoplastic process. In this coronal autopsy specimen, we can see that there is a lot of abnormal appearance in the periventricular tissue. We can magnify it here, and all of the periventricular tissue in this patient was infiltrated by primary CNS lymphoma and small round blue cells. From the same patient, we can look at this magnified H&E section of the frontal horn, and we can see how grossly bluish the region is. And we can also see after a reticulin stain that the tumor has a deposition of reticulin around individual cells, and that accounts for the older name for primary CNS lymphoma, which was reticulum cell sarcoma. So again, primary CNS lymphoma is densely cellular, primarily begins as a perivascular infiltration of small round blue cells with reticulin that surrounds individual cells. If we look here at this high power view, we can see surrounding the two blood vessels all of these small round blue cells,